introduce our first speaker, who is Dr. Bharat Nathoo. Now, Dr. Nathoo is a nephrologist at Mackenzie Health with special interest in diabetic kidney disease, autosomal dominant polycystic kidney disease, chronic kidney disease, and dialysis. He is the past physician lead for the chronic kidney dialysis program at Mackenzie Health. He started the dialysis program at York Central Hospital, which is now Mackenzie Health, in 1996. He is also served as the chair of section of Nephrology Ontario Medical Association, as well as on the committee of Ontario Renal Network. Dr. Nathoo's talk is on kidneys. What do they do? Malfunction, and then what? Dr. Nathoo, it's my pleasure to introduce you. Please take it over.
Thanks, Kevin. Let me just get my screen up. Okay. Are you able to see my screen?
Yes.
Okay, thank you. So thanks for the introduction, Charles. And thank you for asking me to present on this important topic. So, you know, I've framed the topic as how do kidneys work, what happens when they malfunction, and what happens after that. So just like how you mentioned that Black men are more likely to get prostate cancer and are more likely to die from it, what happens with Black people and kidney disease? So Blacks have a 3.7-fold higher prevalence and 3-fold higher incidence of end-stage renal failure as compared to whites. And this disparity is only partly explained by known determinants of end-stage renal disease. That means hypertension, diabetes, socioeconomic factors, and the presence of a gene called ApoL1. So there is a genetic background. And what they've determined is that ApoL1 is a gene that came over from Africa. It used to protect people in Africa from sleeping sickness, but when they migrated and came to North America, this gene became obsolete, but it kind of then put one at an increased risk of getting kidney disease. And that was noted some years ago that if Blacks had hypertension or they had diabetes, there was higher rates of kidney disease. In fact, when you look at COVID and COVID affecting kidney disease, we found that Blacks again had more kidney disease as compared to the other population. However, we also know that everybody who carries this gene does not show evidence of kidney disease, suggesting that the environment also may influence the path of kidney disease. And just to demonstrate, if you look at the red line, this is from the United States. The number of new people starting dialysis in the US is about almost 1,000 per million, as compared to the whites, which is about close to 300 per million, showing again that there's a 3 times higher risk of kidney disease in African Americans. And as Charles has alluded to, in the US, you have, like in Canada, he said 2.4 million. In the US, you have 37 million. That means more than 1 in 7 has kidney disease. And again, only 10% of people know that they have some form of kidney disease. So today we will discuss what are kidneys, what will they do, what is chronic kidney disease, ways to prevent chronic kidney disease and kidney failure, and treatments for kidney failure. So what are kidneys and what do they do? Kidneys are 2 bean-shaped organs located in our lower back and just below your rib cage. The kidneys are vital organs, and if your kidneys fail and you don't get treatment, you will not survive. You need at least one healthy kidney to live, and that's where you have that people can donate a kidney to others who have kidney failure. And if I had to take a look at a kidney and we cut it in a cross section, this is what it looks like. There's what we call a cortex here and a medulla. So this is the outer core that we look at. And then if I had to inject a dye into the artery of your kidney, this is what a kidney looks like. You have a big vessel, the kidney renal artery, and then it branches off into many small blood vessels. And if one has to see how you would get rid of the dye, this is what we do to look at what I call the plumbing system, and the dye is excreted through what we call the ureters and into the bladder. So what do kidneys do? Well, they filter the waste and they remove extra fluid out of the blood, and they make urine. They also help to keep your bones healthy because they activate vitamin D to become the active form that helps your bones stay healthy. The kidney also releases a hormone called erythropoietin that makes red cells. It also releases a hormone that controls your blood pressure. And it also regulates the right amount of minerals in your body. The other important thing the kidney does is that it breaks down insulin. So, I always hear people when they come to see me telling me my diabetes is better, but they got kidney disease. And the reason their diabetes looks better is because the insulin that they have in the body is not being broken down and it lasts longer. The kidney can also make glucose when someone fasts. And the kidney is also responsible for getting rid of medications that you take. So that's why we quite interested in what medications people take, because medications themselves can have a negative effect on kidneys if the kidney function is not normal. So how do they work? Well, as I said, they will filter your blood, and then you will make urine. The urine flows from your kidneys to your bladder through the two tubes called the ureters. And on the right side of the screen, you'll see that the blood enters the kidney, and then the clean blood flows back through into the body. And the yellow part shows you the urinary system. Just to get more into the nitty-gritty, and if we had to expand on that further, this is the kind of scheme that the kidney you would see when you look under the microscope. That you have a thing called the glomerulus, where the blood enters the filter, and then you would make urine that goes down the brown pathway. And there's a different sections that we call initially the proximal tubule, the distal tubule, the collecting duct, and there's something called the loop of Henle. That's this area here. And if I had to take the glomerulus and look at it under a microscope, this is basically what it would look like. So your blood, and I call this the microchip of the kidney. So you have blood that comes into here. It goes through this kind of squiggly blood vessels, and then your clean blood would come out through the other end. Because of different forces, you would then make urine, which would come out through here. So, or we would call this a filtrate. So just to go back, that's how it looks on a grand scheme. But if you take the red portion and you cut it open, this is what you would see. And this is why we would do a kidney biopsy, to see exactly what is happening in the filter. Another scheme is, that's your filter. Again, your urine is flowing down in this brown pathway. Now, so the filtrate, that means the amount of fluid that we make in this brown section, we would make 108 in a normal person. We would filter at least 180 liters in a day. And the kidney gets a lot of blood flow. So every time your heart beats, 1/5 of it is going to your kidney. Now, when you look at the tubules, if you had, we're not going to pee out 180 liters. So what happens is 99% of that filtrate is reabsorbed. So at the end of it, all you are passing is about 2 liters of urine in a day. So we filter through that space, and we would get about 180 liters per day. We would reabsorb the fluid and certain solute, that means salt, glucose, and we would absorb about 178 liters per day in a person. And in addition, we would add other solutes into that fluid that you pee out. And so at the end of it, you would pee out only about 2 liters roughly in a day. So the filter and the tubules, they operate together in concert, and we have something called a tubular glomerular feedback. It's like an orchestra, so it kind of figures out how you're going to do all the filtration, the blood flow, etc., in the kidney. And so when we look at how we explain to people as how much your kidney is working, we use what we call the glomerular filtration rate, the GFR. So the GFR correlates with the other functions in your kidney. So that's all and good. That's how a kidney will work. So if you follow from that if your kidneys get damaged, what's going to happen? So you will have waste build up in your body. You would have extra fluids that stay in your body. And that will lead to something we call chronic kidney disease. Now, chronic kidney disease is where your kidneys are damaged permanently. So we have 2 types of kidney disease that we can, that affects the kidney in a harmful way. One is called acute kidney injury, and that is like, someone gets into shock situation, and the kidneys were working well one day, and because of some catastrophic event, the kidneys shut down the next day. That's called acute kidney injury, and those people, there is a prospect that the kidneys can recover. Chronic kidney disease, on the other hand, it's permanent damage to the kidney. That means your kidney is not going to get any better. The damage will not go away, but over time can get worse. And when someone has chronic kidney disease, what we are trying to do is to slow the damage and hope that it doesn't get any worse as time goes on. And as I said before, we talked about the GFR. So the GFR can also be likened to the percentage your kidneys are working. And based on your GFR, we would categorize your chronic kidney disease into 5 categories. And we have like stage 1 to stage 5. Stage 5 is where we are thinking of dialysis, and most people on dialysis are at stage 5. Usually their kidneys are working less than 6 to 8% when they are in stage 5. If they are below 15, some of them may be on what we call a medical management, that we're treating them with medications, etc., and following them. Anybody who's in stage 1 and 2 is considered normal. So anything above 60%, that means between 60 and 100%, that person has normal kidney disease, normal kidneys. So although we call it stage 1 and 2, it's like a misnomer, and it shouldn't be chronic kidney disease. It's probably normal kidney function. Anything below 60 is said to be chronic kidney disease. So as we, chronic kidney disease can get worse over time. And why, initially we spoke about the fact that very few people know about their kidney disease, because when you are in stage 1 to 3, there is no symptoms whatsoever. It's not like you're going to feel anything. You're not going to have any kind of symptoms. And you may not have any symptoms until the kidneys are very badly damaged. So I would see people that have been pretty healthy and come to see me in stage 4 and say, I feel fine. There's nothing, I don't feel any different. And it's only when you get closer to stage 5 is that we start to see symptoms. And how do you know if you have chronic kidney disease? And the only way you're going to know is if you go to the doctor and you get a blood and urine test. And once your kidneys start to give you symptoms, what are you going to feel? You may have itchy skin, you could have cramps, you feel nauseous and you want to throw up. And that usually happens in the advanced stages, just before you need dialysis. You don't feel hungry. So what happens is that a lot of time people start to eat less. Some of them get put off meat and high protein foods. They may get swelling in their feet. Urine, they may pass lots of urine until the kidneys are ready to fail. So they may have decreased urination, but most people have significant amounts of urine until they're ready to come on dialysis. They may get short of breath. They may have trouble sleeping. So these are some of the signs that when someone has kidneys that are getting quite significantly worse. Other problems that we can pick up is that if we do a blood test, they don't have enough red cells, anemia. So they may be anemic. They may be getting more gout than usual because the uric acid is not being peed out into the urine. They may have electrolyte abnormalities, and especially potassium. The potassium might get high that we have to take some action to lower those potassium. So who's going to get chronic kidney disease? And the answer is anyone can get chronic kidney disease. But if you have certain characteristics, you are more likely to get chronic kidney disease. So if you have a family member with with kidney disease, the chances are higher. If you are races, the black race, Hispanic, Native American, higher risk of getting kidney disease. If you have diabetes, higher risk. If you have high blood pressure, higher risk. If you have heart disease, there's a higher risk. And as you get older, the risk also increases. So the number one cause of chronic kidney disease that we all are aware of is diabetes. Over 50% of the people on dialysis are diabetic. So, and if you look at it, anybody who has diabetes, there's about a 1 in 3 chance that they will have chronic kidney disease. And if you have high blood pressure, there's a 1 in 5 chance. And because high blood pressure is the number 2 cause of chronic kidney disease. So just to reiterate, the number 1 cause of chronic kidney disease is diabetes. And 1 in 2 of our patients on dialysis is a diabetic. So what does high blood pressure mean? High blood pressure is, your heart is pumping blood through your blood vessels, and the heart has to work harder. This can damage your blood vessels in your kidneys, and it can cause chronic kidney disease. But on the flip side, the chronic kidney disease can also make your blood pressure higher. So when we categorize blood pressure, we want blood pressure to be below 140 on 90. And that higher than 140 on 90, we would call high blood pressure. So diabetes is where one has very high blood sugars in your blood. And it's over time. So someone who gets diabetes is not going to get kidney disease straight away. You're going to get kidney problems 10, 15, 20 years down the road. So we're seeing people after a lengthy period when diabetes has had time to have an effect on people's bodies, people's blood vessels. And if we have to say you're diabetic, it means that your blood sugar, when you were seeing the doctor, was 7 or higher on your fasting blood sugar. And there's another test called the A1C. And if your A1C is above 6.5, people are told to be diabetic. So, as I said, the only way you're going to know if you have chronic kidney disease is if you're going to get a test. So what test would we do? We would check for protein in your urine. And this helps to tell us what damage is happening to your kidney. And if there is protein in your urine for 3 months or more, you may have chronic kidney disease. So I liken protein in the urine to a motor car engine, in the sense that if the car is leaking some oil, you know there's a problem. So the same way, if your kidneys are leaking protein, there is a problem. And what we look at is something called an albumin-creatinine ratio, or the short term we would use is an ACR. And the values I've got there at the bottom. So albumin, as we all know, it's a type of protein. Creatinine is a waste product in the blood, which is measured through your urine. The second test that we would look at is your EGFR. The EGFR is a measurement, or what it's said to be an estimate of how much your kidneys are working. And it's based on a blood test that is done. And the blood test we would do is serum creatinine. And that would then, using someone's age, we would then do a mathematical formula and estimate what the GFR is. That tells us how well your kidneys are working. And if your GFR is below 60 over a 3-month period, then we would say you have chronic kidney disease. It would be hard to say just on one test alone. Then we would stage you, as I said before, from stage 1 to stage 5. And anybody above 60 is normal, below 60, they would categorize as chronic kidney disease. So if we know what causes a chronic kidney disease, what can we do to prevent chronic kidney disease and kidney failure? So as I said, the damage is permanent. It's important to get tested. And the steps that one can take to keep yourself healthy as long as possible as follows. Control your blood sugar if you have diabetes. Control your blood pressure if you have high blood pressure. Eat healthy and be active. Also, diabetics need to take the medication as instructed. They need to check their blood sugar and track it. They need to keep it in the normal range and meet with the dietitian so that there is a healthy plan that is right for that individual. And recently, they had come out with these guidelines, which I call the pyramid of care. for people with diabetes and chronic kidney disease. So right at the bottom, you got the foundation of diet, exercise, stop smoking, and keeping your weight in track. Then the medications that you would take include metformin. And these drugs here, SGLT2 inhibitors, are the new wonder drugs on the market. The other names for that is Invokana, Forxiga, the Jardians. And they have slowed kidney disease by about 35%. They've also reduced heart mortality and heart events. So heart failure has been significantly reduced by these drugs, which are called SGLT2. Then we have what we call RAS blockade for kidneys and blood pressure. And in this, we would put medications like candesartan, irbesartan, ramipril, perindopril, the Covisil drugs. And then people will be taking a cholesterol pill, the statins. Then we're coming to newer medications that have just been launched, and these are called MRAs, and they've been shown to help your kidney and your heart. And these are the newer drugs that are starting to have some benefit in diabetics. And the main one that's been in the news a fair amount at the moment is Ozempic, which has been called a Hollywood drug because everyone's using it to lose weight. And as I said, the risk factor control your cholesterol, control your diabetes, control your blood pressure. So it's nothing very complicated. And if one follows this triangle, they do expect that there's going to be a significant reduction in kidney disease as a result of diabetes in the next 10 years. And if you are, then you also have to make sure you get yourself checked every 3 to 6 months and having your blood checked to make sure that everything is staying in a satisfactory range. So again, your blood pressure, take your medicine as instructed. Have a home blood pressure machine, as we are relying more on home readings rather than what you would get in a doctor's office. Get to regular doctor visits. Make sure you restrict the amount of salt in your food and eat healthy fats and lean proteins. Be active and maintain a healthy weight. Now, we would encourage people to be active for 30 minutes, 5 days a week. And we would tell people that it's good to start slowly and build a routine and figure out which is the best way that you can be active and keep yourself to the goals of getting 30 minutes 5 times a week. So what are the other ways of preventing chronic kidney disease? As we said, stop smoking, limiting alcohol. Now, alcohol doesn't affect the kidney, it affects the liver, but alcohol can have an effect on blood pressure. So that would be one way that alcohol would have an effect on your kidney. And make sure that you have a physician that you can discuss these issues with. And it's important that people who want to prevent chronic kidney disease know the numbers. They need to know if they're diabetic, what's their blood sugar? What's the A1C? And the A1C they would do every 3 months. What's your blood pressure? And you can do this every day, but minimum 3 times a week to know what your blood pressure is. Measuring your GFR, and that can be done once or twice a year. And measuring your urine test for any protein, and that can be done every 12 months. So as I said, these are the steps you can take or someone can take to know what their kidneys are and how they can prevent chronic kidney disease. There's those that unfortunately will continue to get worse. And if someone gets worse and enter that stage 5, the question comes as to what are the treatments for kidney failure. So kidney failure that we deal with in the advanced stage, we would call it end-stage renal failure. And those people, the kidneys are working not too well. They're usually around 6 to 8% when someone starts dialysis. They're not working well enough for someone to feel okay, and they may be sick, and they may be in quite significant problems at that stage. And they may need dialysis or a transplant to stay alive and have a good quality of life. The main treatments for kidney failure are threefold. Firstly, dialysis. Secondly is kidney transplant. And thirdly is medical management for those who decline dialysis. So I know there's a speaker after me who will speak on this, so I'll just give a broad overview. So what is dialysis? Dialysis is a treatment to clean the blood when the kidneys are not able to. It does some of the work that the kidneys do when they were healthy, but only about 10% of what a normal kidney does. So that's why dialysis cannot cure all the symptoms. They cannot function like a normal kidney. There are two types of dialysis, what we call hemodialysis, and the other is called peritoneal dialysis. Hemodialysis is where we use a machine to clean your blood. It can be done in a dialysis center, or it can be done at home. The machine can be placed at home, can be done during the day or at night. If someone comes to a center, that usually the treatments are 3 days a week for about 4 hours. If someone does it at home, they can do it at night, or they may do it 5 to 7 times a week. And the system basically is a dialyzer, which is a filter that does most of the work by removing the waste and extra fluids. Then there's the tubes that carry the blood back to the person or takes the blood back out of the person, and also the filtrate. And there's the machine itself. And you need some way of taking the blood out of a person, and we could do it through a needle in the arm, through what we call a fistula or graft, or there's a tube in the neck which is called a tunnel dialysis catheter. And as I said, you can do this at home. You could do it 6 days a week for 2 to 3 hours, or you could do it at night. And with home dialysis and the frequency of it gives you a bit more benefit in flexibility, that you're not fixed to a regime that you have to come to a center 3 times a week. Peritoneal dialysis is the other form of dialysis. And that is where we would put fluid in your belly. And then that fluid is then drained out again into a drain bag. It can be done in any clean, dry place. It can be done, and we don't need a machine, although there's there's 2 types. One, that no machine is required. The second type is where it's done throughout the night, and that requires a machine. The favored route is a kidney transplant. And the kidney transplant is where doctors may put a healthy kidney from someone else into a person with kidney failure. This is the treatment of choice because it makes people live longer. People feel better. The only issue after that is you have to take medications that affect your immune system so that your body doesn't reject the transplant. And those treatments can have side effects. But overall, this is the treatment of choice. People live longer and have a better quality of life. And the types of transplants that we do is what we call the living donor. That means the kidney comes from someone who is living. The living donor may also be a paired kidney donor. That means the donors and the recipients are swapped. So that means person A has a donor B, but the B donor doesn't match A, but it matches someone else. And then there would be a swap of the donors so that the patients get a kidney that is suitable for them. Deceased donor transplant occurs when someone has died and they put up the organs for donation. And that's the other more common form of transplant. Medical management is where, where someone has said they do not want dialysis. And that is basically where we provide comfort care or supportive care. And we would treat the symptoms of their kidney failure without dialysis or a transplant. People can live comfortably, but they will not, it won't keep them alive. And it's more common that we find this in someone who's elderly and he has lots of medical issues. They may decide that, the dialysis is not something for them. So when kidneys are permanently damaged, we call them chronic kidney disease, short-term CKD. Most common cause of CKD, diabetes, high blood pressure. Diabetes is the main actor. High blood pressure, the supporting actor. The symptoms do not appear until late stages. So the early stages, if you want to know you have any kidney issues, it's only by a blood test. And you can try and help prevent chronic kidney disease and kidney failure if you look after diabetes, high blood pressure. And today in 2023, we have significant medications that can help achieve those goals. Eat healthy, be active. Thank you.
Okay, thank you, Dr. Nathoo. Are there any questions in the chat? Okay.
I'm going to read them out. So is there a correction factor used to calculate GFR for Black people?
There used to be. In just the past year, that has been taken out because there is no reason to have a correction factor. In fact, by having the correction factor, they found that Black people were being disadvantaged. What happens with the correction factor, your GFR was set to be higher as compared to the other races. So the Blacks were being disadvantaged as far as getting onto dialysis sooner or even being considered for transplant sooner as compared to the other population.
Are blood and urine tests part of the annual physical?
They should be. They should be.
So if we go for annual physical and the doctor doesn't request it, we should be requesting it.
Absolutely.
Excellent. Are there any other questions for Dr. Nathoo? It's very informative presentation. There's another one here. I have read where certain foods such as asparagus can improve kidney function. Is this a fact or fiction?
So the food will not improve kidney function, but it may help you slow the damage to kidneys. So many years ago, there was a study called the modification in diet in renal failure. And the outcome of that study, where the NIH spent about $25 million on that study, was inconclusive. But I think, if you want to look at recent data, there's data that says that if you eat more non meat proteins, so vegetable proteins, that may help benefit slowing the damage to the kidneys.
Okay. Someone wrote, I am disappointed that doctors are not more forthcoming about the results of blood and urine tests. For example, what it means to have a protein spill in the urine. Information such as this will enable us to be more proactive when discussing test results with our physicians.
I totally agree. And I think the emphasis is now trying to shift to people to know what they should be doing. So they should be challenging the physician and say, you know, have you checked for this? Have you checked for that? And that will put them in a better place going forward, and get more information out of the physician.
Someone wrote, excellent presentation, but my question is, what can be done to decrease the use of medication that causes acute renal failure, or CKD?
So the medications don't cause CKD. Conditions cause CKD. So diabetes causes CKD, and you have high blood pressure causes CKD. Then you have some genetic disease like polycystic kidney disease that cause CKD. Medications can cause acute kidney injury. And to give you an example, if someone is elderly and takes a lot of Advil, those medications can cause a negative kidney effect. Sometimes you're in a hospital and they can give you antibiotics. Some of the antibiotics can have a negative effect on kidney function. So in a kind of a outpatient setting, you're looking at, you know, anti-inflammatory medications that can cause the kidneys to get worse, especially in someone above 65. In other medications, sometimes when you are taking medications for your diabetes, for your blood pressure, there are certain precautions you need to take, that if you are getting dehydrated, if you have any stomach flu, nausea, vomiting, that some of these medications should be stopped, because some medications are good to be taken when you are healthy, but not when you are sick, in inverted commas.
Okay. Can you provide a quick explanation of paraprotein level?
Yeah, paraprotein is it's an abnormal protein released by your immune system. And what happens is that your immune proteins, you get one paraprotein, you know, if you get like when you looked at COVID, you had an antibody response. And paraproteins are like antibodies, but there's a special clone that arises because the bone marrow is making extra of that protein. When you're making a small amount of that paraprotein, it's, you know, it's something to be monitored. And if you take a population, you might have at least 5% of people walking around have the paraprotein. The concern is when those 5% of people, how much will go on to have something called myeloma, which is a cancer of your bone marrow. And that becomes a significant issue.
Can you explain autosomal dominant, and is that a factor for Black people?
So it's not a factor for Black people per se. So as I said in my presentation early on, there is a gene called ApoL1 that Black people have. And I see 23andMe are advertising that they are now doing this gene test. And you know, it's present in Black, but it's not like an autosomal dominant thing. I think it's something that came across from Africa, from evolution. Autosomal dominant polycystic kidney disease can happen in Blacks. Now, this is a condition where a parent who has polycystic kidney disease, which is like, I call it a bubble wrap kidney. The kidneys are full of cysts, pass it on to 50% of their children at a minimum. And some of them will end up with kidney failure, needing dialysis and transplant. Some may not.
Okay, what about medications taken for hypertension that causes retention of water? Also, what are the negative effects of long-term medications, like decades of taking medication?
So all the blood pressure medications that we have for high blood pressure are safe. We've had no signals that they cause any cancer or anything worse on your heart. One of them, those that are called calcium channel blockers, and of them is amlodipine or Norvasc. The other one is Adalat or nifedipine. They may make you retain some fluid in your legs. It's not dangerous. It's just that, it feels uncomfortable, but it doesn't cause any other untoward effects going forward. What we do know is that having high blood pressure will shorten your lifespan if you don't treat it properly, because there's higher risk of getting kidney disease, higher risk of getting strokes, higher risk of heart problems. So they've done many studies on high blood pressure, and it all comes down to that the medications we have today are pretty safe. I wouldn't be too concerned about any long-term effects from that. One should be concerned about the long-term effects of the disease they have. And as I said, diabetes after 10 to 20 years, a fair number, 1 out of 3 have chronic kidney disease.
Listen up.
Yeah.
Listen up.
There's another question. Is frequent urination an indicator of kidney disease?
No, it's probably more indication of a prostate problem in men.
What about women?
It may be because of the pregnancies they've had. So it's a lower urinary tract problem.
It's another one here. As a type 2 diabetic who has recently been prescribed Jardiance, I'm experiencing weight loss. Why is this, and how concerned should I be about my health?
So weight loss can happen on Jardiance. I would not get concerned about it because all this, there's been patients on these medications and they've enrolled almost 100,000 patients. We take all the trials that have been done. There is a certain degree of weight loss, but in the long run, it's going to reduce kidney problems, it's going to reduce heart problems, and it's going to reduce mortality in people with diabetes.
Yeah. Said I've read where the upper acceptable creatine level is 1.3. Generally, how long is the progression from 1.3 to 1.6, which seem like a narrow window from normal to chronic kidney disease?
Yeah, so that's why we say that, we wouldn't take one number. We would take the numbers we would take a level now, then after 3 months, because there is a variability in how the lab measures creatinine too. So we can have about a 10 to 15% variation in how the measurement is done. Going from 1.3 to 1.6 also depends on the kinds of medications someone takes. So to give you an example, if someone is taking Jardiance and the creatinine was 1.3, and they came back to see me and the creatinine had gone to 1.6, one wouldn't be too concerned because we know that these medications sometimes increases the creatinine, but in the long run, they're beneficial.
Okay. We just have 2 more questions. Someone wants to please address again the issue of multiplying by 1.5% for eGFR for Black people.
Yes, so we don't do that anymore. And whichever lab is telling you that is totally wrong. You take the level that is explained without the correction factor. Because as I said, a disservice was done because you categorize the blacks as having a higher GFR when we don't have any evidence to support that.
Yeah. Does long-term use of antidepressants have an impact on the kidneys?
No, these antidepressants that they have no effects on kidney function.
And the last one is, should one be taking Jardiance and Ozempic at the same time?
Yes, you can take Jardiance and Ozempic at the same time. We've just been in the diabetic studies. They've used both of them without any issues. We've just a kidney study is now ongoing, where we have people are being put on. They already now the Jardiance kind of medications are standard of care for diabetic kidney disease. Ozempic is being added on to see whether there's additional benefit in people who have kidney disease as well.
Okay. So Dr. Nathoo, we really want to thank you for an excellent presentation. Very informative. It falls along the message of the Walnut Foundation that people should know their numbers, take care of their health, which is the #1 priority. Dr. Nathoo's presentation is going to be posted on our website after this series, so you can actually go back and look at it again. Okay, thank you very much.
Thank you.